First of all, I will give thanks to the organization committee for inviting us to be here, and also to Oyasama, the distribution of Guna collagen in Spain, who has contacted us, or my group, with this congress and with the organization. What I will call you is a little bit the story of what we have had, the problem that we have had in our hospital to introduce collagen. This is a short summary of what I am going to talk about. As you know, epicondylitis, tennis elbow, is a very prevalent illness. Some papers talk from about 1 to 3% of population, but 80% of the cases has a spontaneous resolution in less than 1 year of evolution. Classical treatments in rehabilitation could be low-level laser therapy, ultrasound therapy, stretching exercises, eccentric exercises. And as Dr. Nestorova said, the problem is what we are talking about, inflammatory problem or degenerative problem, epicondylitis or epicondylosis. In our cases, we are sure that these are, our patients have a degenerative problem because, as you can see, I will talk about patients with a long-term evolution of the problem. And we don't know what to make with this patient after close to 1 year follow-up. We have shockwave therapies, we have surgeries, and in 2012, collagen appears in my life, and we try to use it to solve this problem before sending patients to surgery. I don't know if this is an advantage or not, but we have a committee in my hospital, and when we introduce a new technology, a new treatment, we must prepare an enormous amount of bureaucracy, and they ask us to make things as better as possible and to measure outcomes like if it was a trial. It's not obligatory to report results, but you have the advantage that you made things in a very strict way to try to complain what they ask. In our case, we decided to use collagen in some different illnesses, but in the kind of epicondylitis, we decided to measure 2 outcomes. Pain, obviously, with a visual analog scale, and function using the DASH, the Disability of the Arm, Shoulder, and Hand Scale. As you know, this is a self-administered survey questionnaire with 3 parts, one general, one for sports, another one for working problems. Okay, here. We have began using collagen, and because we saw surprisingly good outcomes in 3 years later. We started in 14, and this was close to 17. We decided to look back and design an observational prospective study trial looking at what we have done during these last 3 years and our results. And we made like 2 phases that I will try to explain. First, we go back to September 14, and we look at patients with refractory epicondylitis, patients where we have used all our, it functions or not, all our issues to solve it, and that they haven't resolved their problem. And we are close to send it to surgery. And as last opportunity, as last chance, we decided to use collagen and see what happens. This is the only inclusion criteria. All of the 21 patients that we recruit are people with repetitive movements in the work, and we ask them to continue working and to continue doing the exercise, changing nothing in their life. We have made a follow-up until November 26, 2016, and we have finished. But in May, previous to our national congress, we decided to call the patients and see what happens close to 1 year later. We have lost 3 patients that we haven't found in May 17. This is how we use the treatment. Pre-treatment, we measure DASH and pain. We have used, as Dr. Herrero explained, twice per week, first 4 doses, and later 1 per week. This is 2 months of treatment. We measure again at post-treatment, 3 months later and 1 year later, both outcomes, pain and function. And later in May 17, we call again the patient. We cannot make the DASH because the DASH is a self-administered questionnaire and you cannot use it by telephone. So we have measured in only the pain, and we have made a Likert scale from 5 points to look at satisfaction. Why? Because we work in Madrid. Madrid is a big, horrible city where traffic is, in the mornings, is espantoso. And we need, so a patient needs to come to us 10 days during 2 weeks. And they are working, and they must go back. And what we want to do to know is if the effort to going to receive the treatment has been useful for them according to the results that they have had. This is our baseline demographic dates. The first column is from the first 21 patients, and the second one is 1 year later. We have lost 3 patients, but you can see that there are very similar results in age, the gender, the laterality of the patients, and the affected site, who is mostly the predominant, because epicondylitis, as you know, is very related with repeated movements. This horrible graphic is to try to explain how we have measured our outcomes. We started with 1 patient. 2 months later, we have finished with them, and 1 month later, we finished the trial. And in May 17, we call again. So we have patients with more than 3 years of follow-up, or close than 3 years of follow-up. All the patients who started with the treatment in November 15, the follow-up is only for 1.5 years. So this is one of the limitations of our study, because not all the patients have the same follow-up. And these are our results. In function, we saw just from the beginning, just after the finishing of injection, that the disability of the arm, shoulder, and hand scale improves significantly. And this improvement is maintained over the time. This is important because patients continue working. We have here involved physiotherapists. We have involved people who work with computers. As you know, one of the most frequent causes of epicondylitis is the use of the mouse in informatics. We have people who work in garden. So there are very, very hard-working patients. But they also improve in the working part of the DASH scale. The improvements are significant and are sustained all over the time. Curiously, we cannot measure the subscale of sports from the DASH. And it's curious because we are talking from tennis elbow. Tennis is a sport. But if you know the DASH, the DASH is a 5-item scale. The sport DASH is a 5-item scale, and patient must answer 4 from the 5 questions to can be measured the results. And we haven't have enough responses to can validate the questionnaire and use it. And in pain, results are similar, but what we saw with pain is that results are sustained over the time. Here there is 1 row more, the last one that is in May 17. From the beginning, patients improve in pain, and this improvement, even if they continue working, is sustained all over the time. And we thought that this must be because we have used the collagen because we have waited close to 1 year. So this is not a spontaneous recovery of the epicondylitis that can appear as in the natural story of the illness. They are chronic patients. We have treated with many different things, including corticoid injection, including everything, and they continue having pain. And these results, this is the real cause what we have looked at the result that we have made this retrospective study, because it surprised us how good it functions and improving pain, and this pain and this improvement is sustained over the time. And I will say now that in 2019, 2 years later, no one of these patients has came back to us with an epicondylitis problem. So it looks like the improvements of results is sustained over the time. And this is satisfaction. Only one patient said that the effort of going to the hospital 10 days compared with the results that he has is not good. But for the other 17, the satisfaction is very great with the treatment. So in conclusion, for us is efficacy treatment, satisfactory result, and keeping time. And what's the future for us? What are we going to do now? At the moment, we have 2 prospective trials running, trying to look if the improvements are not only in function, in pain, but are also in the ultrasound image of the epicondylitis, of the tendon in the insertion in the epicondylus. Thank you very much.